Welcome everyone. Welcome to our international executive roundtable. I believe I know many of you here, but just by way of introduction, my name is Manuel Serapio, and I serve as faculty director of Institute for International Business and Center for International Business Education and Research. As most of you here know, CU Denver is one of 16 centers of excellence in the country in international business called Center for International Business Education and Research. We are the only one in Colorado who has the cyber designation. We're one of 16 in the country, and we're one of 6 or 7 that have had this designation for the past 30 years. We have to compete every year. So we're very, very proud of this, and part of my job is to share these excellent achievements with you. I also teach international business and entrepreneurship at the business school. I'm associate professor, at the business school, and I also run the international business program. Let me start by, recognizing my team. Karen Friedhoff, Kayla Kalabani, Hannah Mikotovich, and we have others here. Nicholas, several members of our team, and my dear friend and colleague, Professor Kao, also in the international business program. As I said, or also the Dr. Jingting Liu. Yeah, and thank you very much for joining us. Dean Dawson will be joining us by Zoom, and we have my 2 colleagues, Associate Dean Mikhailichenko, Dean of Programs, Associate Dean of Programs, and also Associate Dean of Faculty, Dr. Jahan Karimi. As I said earlier, we have our donor here, our benefactor here, Mr. Greg Gibson. Greg, thank you very much, for joining us and your, continued support. It is my honor and my pleasure to introduce our distinguished speaker, this afternoon for this International Executive Roundtable. We've shared with you, his bio. Let me just highlight a few things. First of all, he serves on the board of our Center for International Business Education and Research. Dr. Lemery is also the Climate and Health Foundation Endowed Chair in Climate Medicine and Professor of Emergency Medicine at the University of Colorado School of Medicine. He serves as the Chief of Section of Wilderness and Environmental Medicine and faculty in the Department of Environmental and Occupational Health at the Colorado School of Public Health. Dr. Lemery was past president of the Wilderness Medical Society. He is widely recognized in his field. He has expertise in austere and remote medical care, as well as the effects of climate change on human health. At CU, Dr. Lemery co-founded the Climate and Health Program that's based at the School of Medicine. We're currently in discussions with him for a collaborative program between the business school and also his program, at Anschutz. In partnership with the Climate and Health Foundation and CU faculty, he inaugurated the nation's first graduate medical education, climate and health science policy fellowship for physicians in 2017, and in partnership with other federal agencies and nonprofits. In fall 2022, the program launched the Diploma in Climate Medicine for healthcare providers, and it's the first of its kind in the School of Medicine, offering a distinction for expertise and leadership in this novel field. Jay, I know you're not feeling very well, so thank you very much for joining us. I would like to welcome you and invite my colleagues here to join me in welcoming you.
Yeah, thank you so much. Apologies I can't be there. My kids had viral everything this weekend, and then yesterday it was coming. It was like a freight train coming. So I called my friend Manuel, and thank you for accommodating me to go to be remote, because I think it's probably best to not infect everybody in the room. And yes, it's a medical diagnosis, viral crud. I'm uniquely authorized to give that self-diagnosis. So hope everyone else is feeling well. Today we're gonna do a little, it's a short talk, but there's a lot here, and I want to be able to discuss with you all, because I don't get a chance to sort of get out of my lane all the time, which is, healthcare providers, to talk about opportunities and shared interests and ways to nexus with the academic business community, and of course, many people with actual real business experience, unlike us healthcare providers who have been trained to take care of patients and really nothing else. So today we're going to talk about climate and health foundations, just a little bit of an overview of what underpins these linkages. I'm going to talk about climate medicine, which what the heck is that? We sort of made it up, and we made it up with an idea that it's an undefined space, allows us to fill it with conversation and comments, and is meant, provocative is probably too strong a word, but it's meant to invoke curiosity, because there's nothing else like, that moniker hasn't existed before. Talk about the diploma, which is really our first effort at scaling up a lot of this education, with the desire to scale up a climate savvy healthcare workforce, which is going to be an imperative that is across many different high level stakeholders, which we'll inventory. And then healthcare system decarbonization and resiliency, which is I think a huge opportunity, a beat different than what we're talking about, and I think are the sandbox with which we can play and create in. And within that, I'll talk about issues around action collaboratives and big green data, and then how do we credential people to be to have authority and credibility in this space. So let's get into it. Climate and health foundations, and I'm just going to invoke my late mentor, Dr. Paul Auerbach from Stanford, who wrote this incredible treatise in 2008, Physicians in the Environment, which is really an elegant why we should care. And I got into this. I do have a modest public health background, but I really have no formal training, academic training in public health. And I got into it through wilderness medicine, which is taking care of people in remote and austere places. And we have a whole separate program at CU that does that. And this essay was really one that invoked physicians to be paying attention to it, because it's really that common denominator of human health. And that was very, it sort of started me off on my journey. And really it was the take home was to use that power of science communication and frame this as not just climate change with polar bears on icebergs, but more with kids with inhalers. And that was really a shift. And this was sort of, I'd say this is the money slide. I think it's past. I think it was maybe 5 or 10 years ago, but really reframing that climate change dialogue to one of human health, because it hits our brains differently. We're not talking about altruism, polar bears on icebergs, save the whales, love Mother Earth, all important parts of the human experience, but hits us differently. Or abstractions, 420 parts per million of carbon dioxide at Mauna Loa. We're at the highest it's ever been, right? Those are different messaging than when we talk about our parents' risk of chronic lung disease and kids' risk of asthma. That's a different imperative to act. And I think that was the grand opportunity we saw, is that the healthcare community needs to mobilize and be in a position where we can, use our voice, which in my mind, we've been punching well below our weight on this issue. And what are we actually doing? What are we talking about? Well, it's using our influence as trusted communicators. Yes, the healthcare, doctors, nurses are the top, doctors, we still are trusted communicators. We still hold the public trust in a very cynical society, to the point when we say to our patients, hey, you should take this medicine. Hey, you need this surgery. Second opinions notwithstanding, our patients generally say, okay, doc. Yeah. Okay. Thanks. Right. And so we have a privileged place in society, and to leverage that as trusted communicators. And it's intuitive to many of us because we practice at the bedside, but it's a different skill set, right? It's different than when we're on the podium talking to people. So we have a colleague, Ed Maybach, at the University of at George Mason University. I call it Maybach's pentad, and I tweeted this out thinking it would go viral, and we got like eight retweets when it was called Twitter. But it's very simple, right? And here, and using a little bit of communication science, it's real. It's us. Experts agree. It's bad. There's hope. Let's break that down for a second. It's real. Yes, it's actually happening. The data supports it. No serious scientist is even debating this anymore. It's us. It is human caused. Humans are responsible. It's carbon. Experts agree. Pick your experts, whatever constituency, but again, no one's debating this anymore. It's bad. There are bad consequences from this. We're going to talk about that. And then too often that's where it ended. But then we added number 5 in the early days, and then you have to have a message of hope, because that's what's going to get people to do something. There's hope. And this is, again, we can go back and forth on policy, but those first 4 are agnostic to what we do. It's more the causality, right? And I think that is where we come in, because if half the room doesn't think there's a problem, you've got no shot. If everyone thinks there's a problem, all right, now we're talking. How do we approach it as a society? We're not going to go too deep into the causes, and I think it's somewhat a waste of time. That's a 101 lecture that we give for first year med students and so forth. I'll go briefly hint to it. Right now, the best synthesis with the most up-to-date science comes out of the IPCC. It's the quadrennial UN report, Intergovernmental Panel on Climate Change. And it's where all the best data lives. It's a synthesis report, right? So it's the data that's been collected from earth scientists and climate scientists all over the world. And it lives there. And it just came out, someone can probably correct me on this, within the last year. And so that's the latest. And really it comes back to this. This is a slide that was mocked up by the CDC. And I love it because it's just so elegant. And when I give lectures or interviews, people always say, Jay, what are the most causative things that we're worried about? What are we actually talking about in climate and health? And so I sort of focus on that inner circle, which is the drivers, rising temperatures, sea level rise, increased CO2, extreme weather. You can parse that out and say weather is a result of rising temperatures, more energy. It doesn't matter. That's kind of the core drivers. The next circle is the earth science effects, severe weather, air pollution, changes in vector ecology, air allergens, water and food insecurity. And then it's the human health aspects is the rectangle. It usually comes down, it's a list of about a dozen that are the big offenders. But you get the idea here. It is multi-sectoral. It's extraordinarily complicated. And again, for those that have a predisposition to international anything, foreign affairs, international business, it is hitting all sectors. But bringing it back home, how do we communicate this as a health risk? And I started calling it a disease because I think it's just easier to explain it that way. I've gotten in some fights about this with other care providers who have a different view. I disagree. I think this is a driver, and I think it actually manifests as a disease. So how do we communicate it? What is it as a disease of? And all right, so it's a disease of infections, right? So vector-borne disease, that's easy. So maybe infectious disease doctors, right? Respiratory distress. We see this every summer in Denver, degraded air quality from wildfires, heat increases chemistry in the air with ozone and other particulate matter, and so it's a driver for respiratory distress, both for the healthy and the um, people, young people training for marathons and triathlons come in and they're like, I never knew I had asthma. And I'm like, you don't have asthma. You've got reactive airway disease because the air quality is so poor, right? So it affects the very healthy, the very old, the very frail, physiologic vulnerable, very young. Food insecurity, droughts, flooding, waterborne illness, right? There's no mystery here when places flood, waterborne disease outbreaks, right? Because that's when we have our sanitation systems get overrun, and where we go to the bathroom and where we live and where we grow our food, we want to keep them separate. And flooding and extreme downpours, which we're seeing more, mixes that up, right? So waterborne illness and diarrheal outbreaks are the result of that. And diarrhea is still one of the leading causes of mortality for children under 5 worldwide. So it's a significant thing. Heat stress, obviously, right? So the temperature goes up. We're seeing more heat-related disease, and not just, people always say, are you seeing more heat strokes? The answer is not really, not in Metro Denver. We don't see heat strokes, but what we see is heat stress, where people come in short of breath. They come in with renal insufficiency or chest pain, exacerbations of their chronic disease, because heat is an incredible physiologic stressor. Mental illness, so a general dysphoria around climate, displacement and trauma, so people that are leaving and forced to leave. 1 second, guys. Let me just yell at my kid. All right. Dad yelled at the kids. Let's continue. Okay, so when we contextualize all of this, right, this laundry list in what's happened with tropical cyclones in Puerto Rico and the Gulf Coast and flooding and displacement, right, for people whose neighborhoods are flooded and then they're just trash and they can't move back. California, or the wildfires, any place with wildfires, we've seen that in our own community, right? 900 homes destroyed, plus degraded air quality. It really is a different thing than the systems approach I just sort of laid out for you. It's a disease of 1, vulnerability, and 2, disasters. And that is really kind of where I had left it for many years as I've sort of thought about this. Vulnerability and disasters, and it fit into what I do for a living, which is emergency medicine. And that's the people that we see in the emergency department. And that's where I finished my lecture. Thank you very much. But we had to keep going because it wasn't the end all. It's a disease of ineffective communications, systems failures, and a lack of leadership. So I'm just going to leave that up there for a second. It was these last 3 that kept becoming the elephant in the room, because just talking about it as a threat to human wellness wasn't working. And I'm like, we are not getting this message across. There's, formidable challenges. It had been, it's a science that had been politicized. And it was something that, as we as physicians, like care providers, just are not used to. So reflecting on that, I tried to find some good leadership skills. You at the business school, I'm sure, have a billion quotes on a lack of leadership. I found one from Truman. I give it a B minus, but it works. But this is where we endeavored to fill this gap and come up with the imperative to lead, which is really getting the word out there. The climate crisis will wreck our health, plain and simple. And that's where this idea of climate medicine began to churn up. Okay, so what is happening? And let me just kind of do a quick inventory. Within the House of Medicine, we're gathering momentum. Now, medicine is, not surprisingly, is reflective of the American population, right? So there's a lot of skepticism out there, even amongst trained medical providers, but it's changing and it's slowly changing. So one of the groups we work with is the Medical Society Consortium on Climate and Health. And this is the grand list, but I can tell you that I think it's now 70 or 80% of American physicians, through the membership of their individual colleges, like, so I'm emergency medicine or allergy and immunology, pediatrics, family medicine, et cetera, are now a part of this group. And it's really designed as a place to a commons, a place to get together and discuss. So that's good. So there's momentum and there's acknowledgement and there's a dissemination of best science. Federal priorities have changed. Certainly in the last administration, we're seeing more opportunities to be able to get our work out there and to influence policy and how money is spent. Right. This is a grand what if, and I think that's probably for everyone everywhere with everything in the United States. What's next? The next election. But for now, this is what the last 3 years have been. When we think about what are we doing within healthcare, we wrote up a grand list in health affairs, which is sort of the business side of medicine, for big healthcare systems. And we said, well, what does it look like? What could we do? And I broke it down into 3 different I guess places or sectors within healthcare. So both academic healthcare and operational clinical. So on campus, thinking about what does a dedicated climate and health curricula look like. I didn't put it in here, but we actually have a textbook on it because we were like, we're writing it and we're putting it together. We might as well write the book. So it's climate change and what's the name of the title? It's climate change and global climate change and human health. There you go. And the imprint's Wiley for those that are looking to get it. Just ping me. I can get you the discount copy. Thinking about novel training programs, active conversations between Anschutz and CU Denver Business School. We just had a meeting about scaling up an MD PhD training program. Those are the physician scientists who are, rather than most physicians, most MDs who work in patient care settings, these are the ones that stay in the labs or advance, basic science, MD PhDs, which is sort of the highest level of medical training, at least at that level. Interdisciplinary research, output advocacy, thinking about merging with global health, social justice, DEI activities, and thinking about what is that, what synergies are there, and the work has already been done. There's a global health program that we work very closely with at Anschutz, and our priorities are very much aligned. In clinical practice, right? So outside of the campus, thinking about how the individual provider or a private group can get savvy on this. And a lot of it is around engaging with them, coming up with best practice policy statements within family medicine or OBGYN, dedicated space within their peer-reviewed journals, engaging with the health society, which we just talked about, giving professional experiences for CMAL physicians, and professionals have to get continuing medical education. So thinking about what that looks like, we'll talk about our diploma, which was where that idea came from. And then social media, greening infrastructure projects, and then enabling providers to become trained up, and they can be advocates as well, which there's a real grassroots swelling across healthcare providers looking for these opportunities and just like, I don't know, I'm not going back to school. How do I do it? And then what I think is our grand opportunity for this group is sustainability and policy. So climate smart healthcare initiatives, renewable energy, reporting of metrics, right? We need data. How do we get that data? What are best practices? It's very different than industry, hospital system data. And we have to have good data so we can have the confidence to act and move on it, and then understand what those feedback data loops look like. carbon offset, divestment, things that are analogous to other industries. And then, of course, hospital system resilience and disasters, right? That's one of the things that we have to make sure in the face of climate disasters that we have business continuity and that our hospitals can thrive and handle surges or power issues and things like that. I trained at Bellevue and Tisch Hospitals, NYU in New York City. And during Katrina, the East River flooded, went into the basement. There's whole, almost books at this point written about the failures there. The bottom line is that an extreme climate event took both of these hospitals offline, anywhere between 6 months to a year, depending on, the different services. And Bellevue is the safety net hospital for Manhattan, for New York City, right? So all these people lost access to primary care, which is problematic. And that morbidity from that, I think, is incalculable. And in fact, it's hard to calculate. So, all right. So what do we do? Who's leading on this? And that's really where we start to iterate on this idea of climate action calls for climate doctors. And again, we're making this up. We're pushing these terms out and see what sticks. But we're floating them in this is from the Council on Foreign Relations. We're floating them in different sectors to try and get a 360. In 2017, we started off training doctors, and we did it one at a time in a very typical construct. GME stands for Graduate Medical Education. These are residents. We would take residents in internal medicine, emergency, family, etc. And then we give them a year, and we would really we train them up in this. I'll explain how we did that and what our philosophy was in a second. We started off with very simple competencies, right? Well, you have to kind of understand the 101, the background, or the root causes and the linkages to health. Then we want to talk about mitigation and adaptation. We want to talk about programmatic development. How do we give them the skills to push this forward in any of the domains that they're going to go out and work in, whether it's academic, public, and nonprofit, political, international, etc. And of course, give them what no physician innately has, which is outstanding science communication skills, because it's so important to be able to do that. And we're not taught that. It's not part of our pedagogical approach. We're told to stand up and talk about the gallbladder in a very competent 40-minute lecture that cites all the papers, right? None of us are up there trying to move the needle in our training. But then since then, we realized that we have an evolution in these core competencies beyond. The printer just went nuts. My kids. Beyond just knowing. So having credible, knowledgeable, and effective leadership. And that's really what caused the evolution of this fellowship that we're talking about, giving them, more of the core competencies, but they're like giving them that credibility to be out there. And the truth is that we're going to need to do this to be able to spar with CEOs and community leaders and policymakers and put a 360 spin on this and be able to explain in different sectors how this all interrelates and to push forward smart policy beyond traditional training in like a public health degree or certainly medicine. And we have to do it because we know that the health messaging has stalled, and it's stalled for lots of reasons. In my opinion, the thing that we can control, besides the obfuscation of science that's out there, is that we need to translate complex interactions into convincing, articulate linkages. So thinking about biodiversity and pandemics, extreme weather and food insecurity, heat and geopolitical instability, all super important, but not obvious to anybody. And that's the stuff that we really need to be paying attention to, and making sure we can articulate that. And then the common denominator is the patient, right? A patient-centric approach. And to me, that's vulnerability. The most important message we can convey is that climate change is that disease of vulnerability, and it has disproportionate effects on the physiologic and socioeconomic most vulnerable. And as a colleague of mine said, the poor and sick are going to get pummeled. So I think that is of incredible importance. And right now, there's not many people that can do that. I mean, healthcare providers, right? So trusted resource, credibly address, convincingly explain, and pull together the dizzy interplay between all these sectors, which is very difficult, and there's no discipline that focuses on that. So that's what we've created. We there's 2 fellowships in the country. There's ours, and we actually endeavor to, before pre-COVID, we picked a small community college in Boston to help them get started. I actually had a credential there, so I was one of the first or the fellowship directors there, and now it's spun off into its own. And we work very closely together, good friends there. But that's it. And there's a paucity of you think about the size of this and the fact that there's still only 2 training programs in the country for this. We've done great. We have 5 fellows a year now, and we've scaled up because with COVID, it gave us the confidence to say that Zoom is in fact a thing. We don't need physicians to work in our emergency room in Denver to do this. And we also had to accommodate these other specialties, which, and again, if you're not sure what I'm talking about, that the traditional graduate medical education construct is that you have a discipline, you learn, and you're embedded in the clinical operations of that group. And we just felt this is so big that we don't need that. We have to accommodate other learners. And so we moved the program from emergency medicine into the dean's office, gave all these people learner agreements. These are our current 5 fellows. And check this out. Look who we've been able to land. And I think professional diversity is so important as other aspects of diversity, because we need people approaching this. This is an all hands on deck thing. So we have emergency medicine, family medicine, internal medicine. Those are generalists, so that feels right. Neurology and neurosurgery. And I said to the neurosurgeon, I'm like, why are you applying? And she's all like, it's all about plant-based diets and cardiovascular risk. I knew about that, but I never knew a neurosurgeon who literally sees the inside of our blood vessels and the damage that unhealthy diets can cause, can speak so articulately about that. Our neurologist is a stroke neurologist, so he's constantly looking at brains that are getting cut off from their blood supply for the same reasons. Palliative care, pediatrics, and then in the green are the people we just gave offers to. They'll be joining us in July. Allergy, immunology, think about aero allergens. Radiology, well, what does that have to do with anything? Radiologists touch all aspects of the hospital and hospital operations. So less about what a radiologist does clinically, more about their influence within hospital systems, which is profound. And we'll talk about that. And then one of our affiliate faculty is an ophthalmologist, and he's an endowed chair at Anschutz, and he really wanted to join our program, so we made him an affiliate faculty. So he's an eye doctor. The hallmark of our fellowships is that we embed them. We get their hands dirty. We embed them with federal and nonprofit preceptorships. So you can see here, NOAA, CDC, HHS, Office of Climate Change and Health Equity, FEMA, EPA, the U.S. Global Change Research Program. That's the first logo, which is it's a 13 federal agency body that writes the National Climate Assessment. and not so much a federal partner, probably misplaced logo, is the National Academy of Medicine, who's doing incredible work on this and, has superior convening power. And then nonprofits, getting our fellows where they need to be. So healthcare without harm is it's the healthcare industries program that talks about healthcare system decarbonization. The municipality of Denver, the CASR, Denver Climate Action, Sustainability and Resiliency, $40 million a year from taxpayer ballot initiative revenue to think about how do we make Denver, how do we advance climate initiatives? So incredibly a creative space. And our fellows are there in just a learning capacity. And so we have one fellow that has two of each of these places, but this is again the tapestry where we all come together and we're learning and we have our pulse on what's happening. We also want to get our fellows out there. Here's Sharm el Sheikh at COP27, the big UN FCCC conference, and getting them on the podium there. So here's different aspects of all the different podiums at COP. It's a big, it's the big grand Super Bowl of climate. And now they have a health day. So there's actually a day where we can really focus on health with all the stakeholders throughout the world, which is very exciting. Okay. So with all that said, we have 5 a year. All right, that's good. That's better than 0, but the world needs more. And then we have providers who are nurses, pharmacists, and they call me and they say, I live in Tampa. I've got 3 kids. I have a booming dermatology practice. I can't take your fellowship. What do you have for us? Because I need to lead on this. And that's where we came up with the diploma in climate medicine. And this is a monster, a heavyweight, 300-hour credential open to all practitioners. And we mimicked some other diplomas that are out there, like tropical medicine and hygiene, which is another diploma that the London School and a few others give. Tulane gives one. But we wanted it to be a superior credential where people could have, DICM after their name as a distinguishing, imprimatur, I guess. So here are the themes. We've broken them down into, it's 300 hours and broken them down into 5 different courses. Climate and Health Foundations, talked a little bit about that. Healthcare Systems, Sustainability and Resiliency, Disaster Response, Energy Policy and Healthy Communities, and then Grand Challenges, Systems and Policy, which is food insecurity, sea level rise, political instability, with cross-cutting themes of climate justice, communication, and leadership. Just to go into each of them a little bit, we wanted our learners to have a kinetic experience, a visceral experience. So the first one, we took them to NCAR up in Boulder. We made them do climate modeling. Why would a doctor or nurse ever need to do climate modeling? And the answer is they never will, ever. Not never. But it gives them a cool experience to incorporate into their narrative so they can credibly be out there saying, listen, I've talked to the people. I know where this data comes from. I know how it's processed. I have a general sense of how it works. And when they give us data, it's really meaningful. And here's how it affects our health, right? Science communication. Course 2 is all about healthcare sustainability and resiliency. We're going to come back to this one, but thinking about what does scope 1, 2, and 3 look like, right? Scope 1 is how much oil are we burning in our furnace in the hospital? Scope 2 is, and someone can correct me, it's, what's the carbon output of patients coming to our clinic? And scope 3 is, here's an IV catheter. It was made in Indonesia and put together in the Netherlands and then flown to New York and ends up in Colorado. What's the carbon imprint of one catheter, right? How do we approach this? And how do we, again, keep our healthcare systems sustainable in the face of resilient in the face of climate crises? Course 3 we just did is at Disaster City in Texas A&M, where we run a mock disaster where our hospital is taken offline by a tropical cyclone. Go. What do we do? Course 4, thinking about energy mix, understanding, the limitations to fracking, how cities can have smart policies to improve green space. What are the pros and cons of these alternative, solar, wind, batteries, lithium mines? What does that mean as we look at as renewable energy? And course 5, really bringing it to the centers of power and understanding how big forces are pulling this all together. Again, the rationale is that none of us in health have been trained to raise our hand for any of this, but everyone is going to need a health angle on climate policies: community, politicians, hospitals, nonprofits, deans, department chairs, government entities. So that's the space we're looking to fill, and with filling space is influence, right? Having the influence, informed, credible, science-based, patient-centric influence on climate policy and the drivers for people to motivate to do things. I want to back up a little bit because this is something we stumbled upon in that course 2, healthcare system sustainability and resiliency. And this is exciting because I think this is where the health and business communities have some low-hanging fruit. And there's a few groups working on it. I want to point out the National Academy of Medicine, which is the grand advisor to the nation, and sets big priorities before they get embedded into actual government, is moving big on this, and they're pushing forward opportunities there and bringing the best minds together to think about this. So what are we talking about? Well, it's getting our hands around big green data and understanding where it comes from and understanding what to do with it. So as we think about the metrics that are flowing in from all things climate and health, earth science, energy, patient vulnerabilities from it. We talked about that at the front end of this talk. Expenditures on green initiatives, engagement, and health outcomes. How do we process it? Well, Lancet's been doing it. Lancet's a medical journal, and they've been doing a annual inventory, which is great. And I love it because it's not just health; it's health informing, but it comes from all other sectors: engineering, geography, food, transport, social, political, media. And so it's a place where you can really palpably see the intersection, because if you haven't gotten it now, you probably have. Like, this is not a health talk, right? This is an everything talk. And that's what climate change forces us to think. We have to think systemically. There are groups like Practice Green Health. It's a nonprofit that healthcare systems can sign up for, and they generate tons of metrics for individual hospitals. But again, when they get them, it's one thing to get them. It's another thing to, like, how do we digest this? And how do we pull from this big green blob of numbers metrics that drive clear, convincing strategies on mitigation and adaptation with, right? Every healthcare system has to think about this, that patient-centric posture. So that's a little bit of what we ought to do and what we should do. And there's a few people out there who are thought leaders and first movers who are doing. For better or for worse, I think for better, we're going to be forced to do it. And we don't know the trajectory of that. But the carrots are there, the sticks are coming. Secretary Becerra of HHS, remember, HHS is a grand financial supporter of American healthcare, right? The government, we don't have a national healthcare system, but the government absolutely supports American healthcare. So here's the leverage. Will Medicare, will they link Medicare payments to hospitals to carbon emissions? And rather than saying no, we're going to try and use every tool at our disposal, right? So there's slow needles are moving. There's a shift. We have here the CEO of the Joint Commission. Climate change is a health equity issue. We're looking to reduce our own carbon footprint in healthcare and review our own standards. Ken Kaiser and Carrie Nadeau. Ken's an old a friend and colleague, works in the West Coast, and he wrote an incredible thought piece in JAMA where he said the federal government should maximally leverage its unique position as a healthcare service provider, purchaser, regulator, and sponsor of research, education, and training, right? So incredible levers to pull. This is where I think that solution space exists. And to bring it back home, I think it exists in our multidisciplinary university, specifically the business school and the Center for International Business, Education, and Research, CU Anschutz, and thinking about not just American healthcare, but global decarbonization of healthcare, which is a World Health Organization priority. And if you go to COP, everyone's talking about this, and everyone's looking to connect internationally on best practices. And then groups like Healthcare Without Harm, who are the nonprofit that everyone's kind of looking towards for mostly dissemination and best practices. They don't do the work, but they disseminate it, and can convene big discussions around it. And when we consider that the U.S. healthcare system, ready for this? I can't remember if I said it, but if I haven't, here we go again. 8.5% of the American carbon footprint, right? Huge. And so it's something we're going to have to think about, is how do we decarbonize that? And yes, this is Chat GPT-4. I just made this last night. So quite dramatic photo. And here's the valley of death. And the reason we have to overcome it is healthcare leaders cannot get reliable, idiosyncratic, specific, bespoke data to their systems to confidently implement initiatives, do capital outputs, and understand how that's going to affect health equity and sustainability and resiliency and decarbonization, right? And that's where we are now. There's no easy way to do it. And the margins of most healthcare systems are extraordinarily slim, and inertia is kind of where we are now. So I think, thinking about this, thinking about how AI can leapfrog traditional accounting techniques to bridge those valleys of death, to get through those, to meet those thresholds for enacting sustainability initiatives. And I think this is where the health and the business sector have to come together. And who's going to do all this, right? And we think about recent efforts around medication errors, infections, and falls in healthcare. For those that are paying attention, right, there are legions of people that healthcare systems put together to think about this in every unit, department, hospital, and hospital system as we sort of go up, the chain. And so what does that look like? What do those curricula look like? And I think we have to start moving into healthcare sustainability training. Is it for all comers? Is it for healthcare providers? Probably both, like masters in healthcare administration, and with a separate track for clinicians, active clinicians. Is it masters, or is it micro credentials, stackable credentials? And these are things that we're actively discussing. The answer is probably yes, all of the above. We can go back and forth about where we are and the risk. And there's lots of buzz about that. How much it's going to cost. Does it really cost that much? Are we acknowledging the risks? Are we ignoring the risks? But the truth is, it doesn't matter, because this is it for our lifetime and many generations' lifetime. We're going to be dealing with this for a while, and it's going to be getting worse. So with that, thanks for the time, and I can pause for Q&A.
Thank you very much, Jay. Yeah, we'll open it up for questions, but first, join me in thanking. Who would like to start? Maybe, our, doctor colleague here, Dr. Arden.
Yeah, thanks, Jay. My question is, are you including sustainable healthcare, innovation, and entrepreneurship as part of the curriculum.
Did you hear that, Jay?
Yeah, and entrepreneurship as part of the curriculum, sustainable healthcare. Yeah, and I'm looking at Jeff, who's nodding. We're writing the curriculum, so we get to. Jeff, let's add that to the list. So yes, no, I think
Sounds like we need a little more.
we yeah, that's absolutely part of it. I think we're in early days, and I think we're right now thinking about, we're inventorying, what do we have here, what do we have at the business school. Okay, are those boxes are checked? What do we need to scale up and build? Who else can help us with that? What partners are out there? But undoubtedly this has to be a part of it, because if you're not thinking entrepreneurially, you're dead in the water with this. Frankly, it's going to be moving so fast, and you've got to teach innovation, or at least make innovation part of metrics of success, because there's no standard approach. It's not accounting, right? What I imagine accounting is, where it's just like, we've been doing this 150 years, right? Very different.
And how are you addressing the fact that you mentioned artificial intelligence as a possible solution, but more and more people are pointing to it as the problem. In other words, it consumes enormous amounts of energy. How do you address that?
Yeah, it's great. It's a great question. I don't know. I think you have a right hand, left hand problem. What's the carbon footprint of AI, and does I'll say there's probably an equation out there, and my sense is that if we have some dedicated research around best practices for healthcare systems to account, especially scope 3, and if you can put I'm not a computer expert, but from what I talk to people, a generative AI algorithm to, one, think about low-hanging fruit actionable items, or and risk assessments, that to me should and ought to eclipse any energy expenditures from running an AI algorithm there. But I'm all about, you have to approach these things transparently, right? So I think, what's the cost versus the benefit, period.
And then in Ireland, in our conference last month, they did address that. The footprint that AI causes, and so many of the tech companies are actually thinking about that now in terms of the trade-off that Jay mentioned.
Yeah, it's an exciting space, and it feels like, what I love about it is it feels like this is the exact breakthrough that I think this particular problem could benefit from. I don't know enough about it. That's not my area of expertise, but a few of us are kind of talking more and more. And again, if we could get, if this could help us, leap over that valley of death, so hospital systems can be confident, because we know these are, at least the first 30%, it's all cost savings. They will come out on top. After that, it gets trickier. I think, the data has shown that, but that those first moves will ultimately save the bottom line, improve the bottom line.
Thank you, Jay. And we have a question from Dr. Mary Long from CU Boulder.
Good afternoon, and thank you so much for a super comprehensive and very inspiring talk. Many of you know me, but I don't know that you know me. I run the Spanish for Professions program in the Boulder campus, and we redesigned our program to have a combination that you're discussing, and I'm going to come to a question. It's not just a pitch, which is health, Spanish in health, Spanish in business, Spanish in environment, and Spanish in media, circling around precisely to complement like the public health certificate, those sorts of things. And I'm focusing on undergraduate education. I think a lot of people in the room and in the screen are focused on graduate education, and looking at this base of this need for communication, leaderships, the complexity, the interdisciplinarity. the humanities support that when they're being creative and moving to do this work. But there's an interesting issue with messaging, right? Because parents who send their kids to undergrad to go to pre-med and go to medical school think they only need a science degree. And then we can see nationally that the humanities are getting cut and cut and cut, and oddly, languages are getting cut and cut and cut. So where do you see the messaging piece? Because the students get it, they're excited, they're interested, but then the larger structures seem to be telling them, don't waste your time on that. You just need to get your like IFI classes in and this and that. Where do you see the link for the messaging that if you take this time as an undergrad, it's going to give you such a valuable base with your fluency, your cultural, cross-cultural communication, your understanding of these issues, and then when you're in medical school, and then when you go on to the larger re-credentialing, you've got this base. Where is the key to the messaging that the humanities connected to all of this should not be eliminated, and to parents that their kids will benefit from this?
Well, there's a larger conversation, one which I'm very much invested in. I have a degree, a Bachelor of Arts in Interdisciplinary Studies. That's what it says. And I was lucky. I had some mentors who said, do liberal arts because it teaches you how to critically think. It teaches you how to write. And maybe Chat GPT is going to do all our writing, but it teaches you how to effectively express ideas. And I think that to me is the crux of undergraduate education. But I also knew I was going to grad school in some capacity, right? And that's where I learned hard science skills. So I would agree with you. I think the one maybe asterisk is, if there's plenty of English majors out there with a lot of undergraduate debt, and I think that's a different problem. So I think that has to be sort of reconciled. But no, I couldn't agree more that the foundation of an undergraduate education allows you to be a provocateur, a critical thinker. That's what everything I just presented came out of myself and scores of like-minded people thinking outside the box and saying, what if? No, we have to do it this way. That makes no sense. That's stupid. Let's do it this way. My chair, who I can say this because I love him and he's been very supportive, said to me, you can't do a fellowship without giving them an advanced degree. You've got to give them an MPH or a Master's of Science or something. I was like, no, you can't, because that's wasting their time. We don't need an MPH. We need somebody who's in DC who knows the CDC and what they're working on, and it becomes besties with them. So when they get out, they can now leverage that relationship. So that type of thinking, I think, comes from being confident in being, from a liberal arts education. So we can go on. I'm happy to talk to you offline about that, but I totally agree.
Thank you. Other questions? Anna?
Yeah, I think it is. This whole concept to me is really interesting. I'm actually in a course on global climate change at the graduate level right now. And literally in my discussion last week was talking to some of my colleagues about things like grading the operating room, using alternative refrigerants in hospital systems for cooling and refrigeration to, reduce fluorocarbons. Things of that nature, and the fact that hospitals are such big waste producers, disposable gloves, disposable masks, disposable packaging for sterile instruments, things of that nature. And I really feel like hospital systems themselves stand a chance to kind of be leaders on the forefront of making sustainability changes in order to, kind of reduce the effects and mitigate and adapt to climate change. So I guess my question is, what advice would you give to someone who has a more, I guess, business focus educationally rather than, you know, kind of a medical kind of focus in that area.
Yeah, thanks. I mean, I think the first thing is, you know, if you're in healthcare at any level, the whole pitch is first do no harm, right? That's Hippocrates, right? So that's the first thing. We have to do better. And we're all mission aligned, patient care, health equity, better bottom lines, reducing carbon footprint is slowly becoming baked into the mission strategy. So I would say in some ways the business case is probably easier than the healthcare provider who's like, I don't want to have to recycle because if I can't have the disposable forceps I can't give good care to my patient if you make me recycle it where it's cheaper, right? That's a lot of old entrenched thinking. But I would say is we need the business community for some of these solutions. Healthcare can never be run as a pure business. In my opinion, it shouldn't be. I think maybe we hit some of that in the 90s. That's a larger conversation. But when you're just looking at the books, and if you give somebody with a business background the mission, get us there, decarbonize, make it more sustainable, and we have to balance the books in 2 years, whatever that is. You know, those are the people that know how to do it. And I think that's what we need. And to understand the operations and the ethos and the culture, business people are very good at that coming into an industry. And, you know, there's tons and tons of MBAs at CU Anschutz, both clinician and non-clinician.
Thank you.
Thank you. Any other questions? Missy, your question?
I have a lot of questions. I think one of the things that jumps out at me is at the doctor level. I mean, this is really a critical element of the calculus. So how do we talk to doctors about when you say, well, a patient may come in saying I've got asthma, but in fact it's not asthma, it's a climate triggered type of disease. How do we get doctors to be able to make that shift? That's a whole level of education that I don't hear, but I'm sure it's there. It's just not being brought out.
Yeah. Well, there's plenty of precedent, right? I talk to people about smoking. I mean, when I was in med school 20 years ago, they're like, smoking cessation is part of your exam, no matter what you're doing. So we changed the culture, right? Society changed the culture. Seatbelts, helmets. I talk to my patients about diet and exercise, diabetics. It's hard to do in the emergency room, but even then there's teachable moments. I can't do it for everyone all the time. I talk to my, sadly young people about gun violence because they get shot and we see them. Those are all social determinants of disease. It's just another thing. Nothing mysterious or magical about it. It's just like, hey, check out the air quality. It's hot and smoky. So I notice you're on oxygen, or I notice you're 70 years old with congestive heart failure. Don't go to the King Supers at noon tomorrow. Go at another time. See if you can have someone bring you groceries. Whatever it is. I think if you just give people a little bit of situational awareness, that goes a long way. And you don't have to. It's quite simple. You just speak from a clinical voice. Which is. It is what it is. I'm not here to, to ask you to embrace that climate change is human cause or things that seem to get, many people in our population still are angsty about or don't want to accept that. But you just say it flat out, and it generally goes on well. Yeah, that's great. Good advice. Thanks.
Yeah, well, I mean, doctors need to have that bridge. Right now, a doctor will, sees a patient and patient comes in with certain characteristics and, the doctor needs to be able to say, yeah, this is more of a climate issue, or it's more of a, disease issue that is born from a virus or whatever. I mean, there's a leap there that requires education for the doctor's part.
Yeah. I mean, that allopathic medicine, which is what we do, right? It's data driven, it's evidence-based. We can't do anything. There's a lot we do that we don't know, but at least our mission is that we don't do anything unless it's considered best practice or data to support it. And so this is all the same. It's in the same vein. We have fought hard to have some level of attribution science on our electronic medical records for coding, whether it's an imprint of the weather that day, and not just temperature, but like humidity and things like that. So we can go back and look at those medical records and say, hey, on July 20th, there was a spike in ICU visits, but it was also when the air quality was the worst in Denver. Are they related? And that's what people do every day in health research. And so, and we also want to look at ICD-10 codes to be able to say, there's the primary code, shortness of breath, chest pain, but there's also secondary codes, environmental exposure. And what we want to actually say, hottest day of the year code, or, other climate codes that can tell a story if we're thinking about it, because then people can go back and look at morbidity and mortality related to environmental health attributed to climate change. It's so important to have that data. And right now our system isn't built like that. Yep.
Go ahead, Larry.
Sorry. Caught me in mid-breath. I think it's interesting the point that Mary made, which is, where does Spanish fit in? And I'd like to address that, because I'm not trying to move this off the topic at hand, but be complementary to it. And I hope Mary's still on the line.
Mary's.
So, I guess the issue here that's so important is that you have to pick your target market segments that you're trying to address about any sort of climate issue. And it's much like communication about smoking. Obviously, they're defined by who smokes and who doesn't, but then there's demographics involved. And I argue that, what Mary should be looking at as a solution to get integrated is the large Hispanic audiences that are pertinent to this issue. And where do they fit in terms of target markets that we're looking to sort of change some of their perspectives on where we're going with some of this information. Because there are many people that are resistant. And hopefully the more education you get, the more open you are to the suggestion of concepts like you've been discussing. So I guess that's a solution that I see for Mary. So if I was looking for this, I'd be teaming up with the marketing people, the champions, of course, at any place you can, Mary. That's the key to survival. And you're in a language field where obviously there's a lot of demand. I realize that's probably more important to Mary than it is to many other people in the audience.
Any comments on that, Jay? I have an international question for you. So, looking at Southeast Asia, for example, my native country, Philippines gets 20 typhoons a year at least. And so they run through the letters of the alphabet. By the time it's August or September, they're almost out. And so they have to go back to A or B. But what has happened most recently is that there are more typhoons and they're stronger. And it's really, really adversely impactful, especially those that you have mentioned, the poor, and underserved. So that's one development. But then on the other hand, you have the big companies, the conglomerates. For example, we took a group of 15 faculty members, to Asia. The group companies have actually gone into hospitals, into medical services and healthcare services, largely for economic reasons, but also for social enterprise, objectives. So, a message such as what you have shared with us will resonate very well with this group who are the providers and also with those who are being impacted by this. But the key issue is cost. You need the innovation, but you need frugal innovation, not like the innovation that we're used to here. What are your thoughts on this and what can be done? This will be well received, but the implementation has to do with the economics.
Yeah, yeah. I think it's quite straightforward. You think about true cost, right? True cost accounting. What's the cost of having a workforce be knocked offline because, you know, illness and injury and loss of housing? What's the cost of building resilient systems in your communities, whether it's, you know, mangroves or you know, better flooding areas or power generators, and thinking about if the next modeling of doing a risk stress test, if the typhoon category 1, 2, 3, 4 hits, what does that look like for us? I think I go back to what I said, which is data is so important for decision makers, and we ought to invest in better data methodologies that can be tailored to bespoke systems, right? Because a hospital in the Philippines, first of all, there's probably not one that's similar, and they're definitely different than the United States. So all these sort of things that are out there right now, because it's somewhat immature, feel as a one size fits all. So I think to your question, it's getting the best data you can. It's saying, look, these things are going to have the biggest bang for the buck if you do this. And it's also true cost accounting, which is basically just an accurate risk assessment. So I can keep going, but I'll stop there.
Yeah. I think in terms of the degree and the training that you have just mentioned, I think that it will connect very well with these countries.
Yeah.
And especially if it's delivered, not in person, but could be delivered, you know, online, and, you know, some train the trainer kind of design. I think it will work very well.
And think about the stuff that we've learned today and then I've learned. But if you're a local healthcare administrator or provider in the Philippines, like, you'll be, you know, infinitely more articulate about what that community needs or what the risks are, right? And that's what we have to do. And if you don't train these people, you don't train, we just don't know. And that's, I think, what's held healthcare back, in my opinion, over a decade.
Right. And conversely, you learn from them because, you know, again, many of the, disease of thing that you have mentioned, you know, that's a way of life for many people in these countries. And so in turn, you know, we learn from them. I'll have Jeffy, would you like to ask the last question before we adjourn? I don't want to put you on the spot. Just wanted to ask if you have a question for Jay.
Of course, I have questions for Jay. Jay, one of the hard conversations that we have around these initiatives from the business perspective, and I appreciate the accounting questions that you raised there. Where do you think we as managers, as leaders in this initiative, where do we go to look for the payback? I've got my ideas, but from the clinical perspective, I think there's some opportunities. What sort of things come to mind there? How do we pay for the changes we need to make?
Well, I think you have to define your metrics of success, right? Because there's very clear traditional things, which is like, hey, our energy bill is 30% less this month than it was last year. Okay, that's easy. But then think about, you know, what does scope 1, 2, and 3 at carbon accounting? So are we reducing our carbon footprint? And that's fudgy numbers. That's why we actually need accepted best practices, so we can all agree on cross hospital comparisons. And then I think we have to think about health equity, right? Because when we think about sustainability, for instance, here's a very simple thing, which is like, hey, on Thursday afternoons, we're going to scale up our primary care clinic and just do virtual visits just like this online. And that's all we're going to do on Thursdays. And you're going to see your carbon footprint has dropped. You actually increase patient care access, right? Because, you know, many of our patients in Aurora, they have to get on the bus and they have to get the thing, and all sorts of reasons that's very difficult for them to show up at 10:15 a.m. for their clinic appointment. But if they just have to get on their phone or online and talk to a doctor, and they can readjust their meds or whatever it is, that's health equity, and you've improved it and you've reduced the carbon footprint. So those are the things that I think we have to reimagine. These are not my ideas, right? These are well-worn things that are out there, but it's an expansive view of metrics of success. And that's why it's different than just a bottom line business, because the patient-centric metrics in many ways, you know, are on top.
That's a really good. That's a really good point about the whole healthcare issue in general. You know, measuring an outcome. You know, if somebody's terminally ill, did they get good care even though they didn't live through the disease? I mean, I think you make a really good point there. But one of the things I really wanted to just applaud you sharing with us is the impact that we in healthcare have on the climate. You mentioned the United States, 8.5% of greenhouse gas emissions. Worldwide, it's over 5, almost 6%. We in healthcare are almost as bad as airlines or trucking companies in terms of what we're doing to the climate. So the questions you raise are really well timed, and certainly things we have got to deal with.
Jay, thank you very much. And again, appreciate you, doing this, though you're not, feeling well. I hope you feel better. And we look forward to continuing our dialogue and, our future collaboration. For those of you who joined us by Zoom, from Boulder, and Miss Scott from, Pennsylvania, and others, and our colleagues here who joined us in person, thank you very much. And to the team who helped put this together, Kayla, Karen, Hannah, thank you very much.
Yeah,
Jay,
thanks, guys.
thank you,
Real
and
pleasure.
I'll be in touch. Yeah, thank you.
Bye, friends.